Today, we are super excited to have with us Joshua Eskenazi and Pavel Bachardo, who are going to talk to us about their most recent work in extended resection. Super interesting manuscript. Jason Sheehan's running a little late. As always, we have Chris Cifarelli with us as well. So welcome, everyone. Pavel and Joshua, why don't you just get started, introduce yourselves, kick it off.
Sounds good.
Yeah, my name is Joshua Eskenazi. I'm a neurosurgeon at UT Houston, and I'm pleased, very happy to be here. Thank you for the invitation. And Pavel,
My name is Pavel Pichardo. I'm part of the pre-residency fellow cohort in Mount Sinai, so I'm really happy and excited to be here. So thank you so much, Dr. Cifarelli, Dr. D'Amico, and Dr. Sheehan for having us at the Seattle Science Foundation. Thank you so much. All right,
No problem. Yeah, why don't you guys pull up your slides and get going?
Sounds good. Okay, so I'm going to start talking about this project real quick. Just let me set it up. And the second portion of the slide is going to be presented by my mentor, Dr. Eskenazi. So, okay, we're going to start to jump right in. So thank you so much for having us. We're going to be talking about the impact of maximal and supramaximal resections and how it could impact post-op DWI changes in clinical outcomes in glioblastoma surgery. This is a really special project. It was during my last time as a research fellow at UTL Houston. As we mentioned previously, my name is Pavel Pichardo, and I'm really happy to be sharing this work. So I have no disclosures, and this was recently published in JNO earlier, a couple of months ago. So as we know, the standard of care for surgically accessible glioblastoma involves maximal safe tumor resection, which has consistently shown to improve overall survival. Whenever we perform a surgery, it basically focuses on two main MRI regions. As we know, there's a contrast enhancing area which corresponds with a necrotic core and also a peripheral rim that enhances with the contrast. However, more and more evidence nowadays is showing how if you even extend the resection beyond this area into the flare region, we can also identify not only some edema, but also some tumor cells that might not be enhancing with the contrast, which we call the non-CE flare region. So aggressive resections can lead potentially to devascularization of these tumor regions, particularly for those involving the flare area. So we wanted to assess like how these can be changed in response to aggressive resections. So we attempted to identify several shapes. As you can see on this figure, the blue pattern would represent the rim shape DWI restriction pattern. The yellow would represent the wedge shape or sector shape DWI restriction. And whenever we potentially could injure an empassage vessel, it could correlate with the pink pattern, which is the remote DWI restriction. So all these maps were assessed with DWI and ADC following glioblastoma surgery. As you can see, like in real time, like all these patients were from the UT Health cohort that we had. The B would represent the sector shape pattern, the C would represent the rim, D and E would represent the mixed shape pattern, F would represent remote, and G would represent no changes whatsoever. So one of the bigger questions we attempted to answer is, can we perform a complete and even supramaximal resections per the Rano Resect classification system in a safely way and comparable? So we attempted to classify our whole cohort of 323 patients that all of them were newly diagnosed GBM IDH-Wildtype confirmed with either immunohistochemistry or even next generation sequencing from 2005 and 2023. All of them were assessed blindly by a neuroradiologist from 24 hours to 72 hours after the surgery in order to be stratified. Basically, our first big cohort of patients was the supramaximal or complete resection cohort that if basically is defined by achieving 0 cc's of residual tumor volume. But if you additionally were able to resect a significant portion of flare, leaving less than 5 cc, that would be called not complete, but now supramaximal class 1 resection. Our second cohort would represent near total, which means achieving a residual tumor volume of less than 1 cc, and then submaximal meaning over 1 cc. So in our cohort, basically, we did not include any biopsy patients. So when we started to analyze our patients, we identified that there was some DWI restriction in 50% of these patients. Most of them most of the baseline characteristics were balanced before the surgery. And whenever we were analyzing the Rano Resect classification, supramaximal resection was achieved in 24 patients, complete 100, near total 57, and then submaximal 142 patients. And As expected, having a bigger tumor preoperatively was positively correlated with DWI restriction volume. However, really surprisingly, the presence of DWI restriction alone, even if it was analyzed in the shape of volume or even any pattern that we mentioned previously, if it was rim, if it was sector, if it was remote, if it was mixed, none of them correlated with worse overall survival by themselves. And really surprisingly, even though our 50% of DWI changes were occurring or happening in our cohort, the vast majority, up to 97% of these patients, were asymptomatic or without any reportable neurological deficits when they were assessed after the surgery. And for the 10 patients that did experience some neurological deficits, they were comparable between the maximal and supramaximal and the submaximal group from one another. So they were as safe. And really most notably, out of the 10 patients, 5 of them were completely resolved by the 1-month follow-up. And the sector shape pattern was the only one that was associated, at least in our cohort, with neurological symptoms. So when we progressed to analyze overall survival, we identified that higher random resect volumetric classes were consistently associated with improved overall survival and KPS without necessarily having more worse neurological deficits. We also analyzed this in the form of a table, and as you can see, median overall survival was increasing as we moved up in the random resect categories without any potential changes, neither in volume for DWI restriction nor incidence of any shape of DWI restriction. So meaning that these were like, even particularly for the supramaximal resection, it was not with a higher incidence of DWI changes. And also neurological deficits were comparable from all the less aggressive resections. And along these lines, postoperative KPS at 3 months was also positively correlated as we move forward up in the classes. We also confirmed all these findings with multivariate hazard ratio analysis, and is aligned with the literature. The presence of performing supramaximal or maximal resection, being younger, having a higher postoperative KPS, and adjuvant chemoradiotherapy positively correlated with improved survival. And most notably is as you can see over here, having the presence of DWI restriction or any shape of DWI restriction pattern whatsoever did not correlate with worse survival. So in conclusion, and to try to continue with our discussion, postoperative DWI changes are common and it occurred in 50% of our cohort. However, the vast majority of these patients are asymptomatic, and most of these can even experience a notable recovery after the surgery. Supramaximal resection, meaning achieving a 0 cc of residual CE, and also a significant resection of the flare region, can be achieved safely and can be comparable to less aggressive resection, which was one of the previous worries that in the literature whenever we perform like more aggressive resections. However, supramaximal resection may not be feasible for all patients, particularly for those that are deep-seated in eloquent regions, as it was represented that it was only achieved in 11.6% of our cases, which may suggest that it might not be amenable for all these patients. So maximal safe resection still represents a key strategy to improve patient outcomes with minimal complications, while also supporting the tools of neuromonitoring and even other additional intraoperative tools. So once again, before moving on to the discussion, I just want to thank Dr. Eskenazi and Dr. Tandem for my time at UT Hall. It was a really wonderful project. So before jumping into this portion, we're going to continue with some of the few slides that we have in regards to try to enrich the discussion. So one second. And now my mentor, Dr. Eskenazi, is going to be talking a little bit more in detail about these upcoming slides.
Yeah, that's very nice, Pavel. And obviously, I'll let Randy and Chris go for the questions. Why did we do this? This is not new. There's been a couple of publications on looking at DWI after resections. We wanted, because of the popularity of the supramaximal resections, we wanted to see if there's really an impact in the percentage of these and if they're becoming more symptomatic, and also look at it in a very well annotated cohort of IDH-Wildtype cases. And while most of them are not symptomatic, and I talked to other groups about this, but the bottom line is that the first sequence that I always look after I do a resection is the DWI. I don't look at anything else. The first thing I do I pull the DWI for the 24-hour MRI, and then I'm like, okay, I want to see, you can sugarcoat the name of DWI, but the bottom line is a stroke, right? It's just a lack of perfusion to an area of the brain. And we like to do mapping. So why is it critical? Although in the majority of the patients, it doesn't impact. This is just a picture. Jared Gerritsen gave me these images last week because we were talking about this. And when you're mapping, right, you're mapping the function. And let's say, move to the next one. So you're trying to find the corticospinal tract or whatever pathway it is, if it's the arcuate fasciculus or if it's a language pattern or a visual function, right? So this is an example, right? The corticospinal tract is right here in blue on this WI. So this is a motor case with a lot of mapping. We get very close to the corticospinal tract. And as you can see, there's almost no restricted diffusion. But what happens if you get 8 millimeters or 10 millimeters of restricted diffusion when you find a corticospinal tract or a language tract at 3 or 5 milliamps, right? Which means 3 to 5 millimeters if you use one of these techniques that we like using. So, some of the things that we're not doing is bipolar at the edge of the resection cavity. Once we get to the edge of the sulcus, beyond the U fibers and the white matter, then sometimes it's difficult not to be able to take out the tumor. So we bring down the bipolar energy, but go on to the next one. So now this is a case. This is a case example, as you can see, motor case again. And you can see this technique, how close we got to the corticospinal tract. We started mapping at 10, 8.2, 9.63. We almost got to 2.8 millimeters, which is 2.8 milliamps. And that's very close. And if you think about it, that you're getting 50 to 80% of these DWI changes. If the change happens to, ends up right at the resection border of your mapping, you're going to knock out completely the tract. So keep going with the next one. Let me show you. These are cases from last week, from the last 2 weeks. This is a nice case, straightforward, glioma. You have a complete resection. This is not a supratotal resection. Why? Because it's almost in the most end back of the temporal lobe. You will need to resect 9 centimeters and a lot of the occipital lobe. But as you can see in the center, there's no restricted diffusion. It's very sharp. Go to the next one. I'm showing this case, very simple case. Complete resection of the enhancing tumor. And you can see there's restricted diffusion, right? And if you measure these DWI changes, they're typically between 8 to 9 millimeters. They can be 5 to 10 millimeters. So go to the next one. So if I were to map a language tract or a motor tract, can you show the next one, Pablo?
Yeah, I think that's the last one that we had.
Oh, there's the vision fibers. Okay. Anyway, there is a case that I wanted to show that I sent a picture to Pablo where you're very close to the vision fibers. So, I was very lucky not to get a complete visual field for that one. But this is something we really need to emphasize more. We never talk about it in the meetings, but these DWI changes are important. And I think it's really, these manuscripts made me change a little bit in my practice when I'm being very aggressive at mapping, because I know that, just by removing the tumor, the devascularization process will cause some of these restricted diffusion. And we don't worry too much about knocking the tract because we get too close to the tract. But we worry when we're there that the DWI changes will cause a deficit. And you can criticize this paper as much as possible, right? We're not doing high cognitive testing. If you think about it, if you get a patient with a pre-existing hemianopsia, and then you get a visual deficit, is not quantifiable, right? Or if you have that picture that he showed on the right temporal DWI change, it's in the non-dominant lobe, it's completely asymptomatic. But that doesn't mean that we're not causing some cognitive deficit that we're not measuring, right? If you really think about the connectomics and judgment and planning, speed of thought, all those things that in general we don't document on the clinical exam. But with that, those are my points of view and the reason why we wanted to do this. If you guys have any comments, Randy and Chris.
Yeah, I think that was great. Thank you both. I think it's a wonderful paper, and I think this underscores the debate that we're having, which is more of like a seesaw than a pendulum. It's not really swinging in one direction or the other. We know we have to get more tumor out. We just know how's the safest way to do this. And what I wanted to get to find out from you guys, I was looking through your data in some detail, and we all see the big non-contrast enhancing tumor patients that have a fairly small contrast enhancing tumor relative to the non-contrast enhancing flare abnormality. And I was wondering if you went back and did any ratio analysis in your patients to say, okay, you had 30 cc's of contrast enhancing volume, but let's say you had 15 cc's of non-contrast enhancing volume when you subtract out the contrast enhancing volume, and created ratios to see were those ones that were more likely to achieve the supramaximal resection. Because if you've got matched, you've got a median of 82 and 86 in your cohorts between the DWI restricted and non-restricted for the median preoperative non-contrast enhancing flare volume. Did you guys go through and try to match those in the same patient at all? Because I think some tumors are proliferative, whereas some are migratory. And this is where I find it's the hardest to kind of figure out, well, what's my goal here? If I've got somebody that's got a quarter of their brain that's flare abnormality, I'm not going to resect a quarter of their brain. How much is enough? And if I've got somebody that literally has a little rim around the outside and it's a matter of going an extra 5 or even 10 millimeters, I'm going to try to do that if it's a non-eloquent cortex. And I'm just wondering what your feel was from your patient population. And is that something you can go back and maybe look at?
Yeah, sure. We certainly didn't do the ratios as you suggested. And I agree, as you saw, the percentage of class 1 patients is very, very small. And it's in accordance with the Rano Resect paper that was published. Actually, all of these patients were part of that paper. And in that paper, it was only 10%. So, we're really not, I'm not going to say we're doing supramaximal resections more than anybody else. We're doing when it's in the anterior temporal lobe or the right or left anterior temporal lobe, or if the patient has a pre-existing hemianopsia, that we can do an occipital lobectomy. And nobody else is doing more than that. And if they are, they're probably hurting the patient. And it may not be a deficit that you can assess, but I've had cases where I'm very, very aggressive with the right frontal lobe, and then the patient has a lot of issues. Like, the wife was telling me, hey, it takes him 45 minutes to sip his coffee, or to send a text message. He can send text messages. His language is almost normal, but the guy takes so long. And now she was saying he spends almost an hour in the shower. Yeah, that's not normal. So there are some things that we're not really assessing that obviously, as you guys know, every part of the brain is eloquent, and there's a reason why it's there. But I would be interested in seeing more groups publish on this. And, again, the novelty of these was that nobody's really looked at the DWI changes in the setting of a supramaximal resection, but it's been done before in other scenarios.
Yeah, I think it's a nice metric, and we all have DWI sequences in our post-op MRI, so I think it's worth looking at. Thanks.
Yeah, I agree. I think it's a really unique way to think about it. You look at DWI. I'm just curious, procedurally, did you look at ADC correlates also? How much of this is infarcted tissue versus just edema, or vascular changes from removing a tumor that presumably has a shared blood supply?
Yeah, no, we looked at the correlate for sure. Otherwise, like a T2 shine through or that kind of, but we wanted to make sure that it is actually, it's a stroke, right?
This is an ischemic event. Yeah.
When you see a stroke in a patient, right, in an ischemic stroke, you always look at the WI and the ADC map. We have to call it the same way. We don't want to say, okay, we're stroking 50-80% of the patients, but we're certainly causing some sort of devascularization phenomena that the adjacent area around the tumor has some impact.
Yeah,
And
I mean, this is the conversation I have with patients during consent, and I'm sure you guys too, where it's, the tumor shares blood supply with the normal brain. And even when you don't sacrifice an artery directly into the tumor, you see this. Whether it's, venous congestion and ischemia due to that, or due to, emphysage microvessels at the boundary. What's fascinating is how little influence it seemed to have on the generic outcomes. But I echo your sentiment about the stuff we're not testing. I saw a guy today who had a posterior right temporal large glioma removed, and I'm a big proponent of connectomics. I mapped everything, and this was going to be a ventral attention issue, which I usually don't spend too much time worrying about. And similar to your patient, this guy he doesn't know where he is. He's very confused. He's agitated. He's not the same human anymore. And in one of those situations, you sit there and you say, should I have taken out only 90% of this? Because did I make him worse now? And I think that even those situations where you can get the whole tumor out, you know, how much risk am I putting the surrounding tissue around? How far can I push that boundary? Which is, I think, your point here. Because if you get to 1 milliamp and you get 8 millimeters of restricted diffusion, how safe is that?
right. Yeah, I think the guidelines of resection are actually, there's guidelines that are coming in the Lancet. This is the first author is Jasper Gerson, and it's sort of like an expert consensus of how far to go on motor, on language, on each specific task. But I'm double guessing. I'm really thinking about it because particularly in very elderly patients, they don't tolerate the deficits that well, like with
No.
very elderly patients. And I'm talking about 70, 80, 85-year-old patients. For some reasons, I think they're very vulnerable. They don't have good like reserve along the microvasculature. So let's say that you stop at 10 milliamps or 8 milliamps, and then you get a little hit that measures 9 milliamps. The patient will be plegic.
Yeah.
It won't happen. And nobody really talks about it. So I
Yeah.
think just for everybody who's watching this webinar, every time you do a case, look at your post-op DWI as the first thing you do, and then see, even though the patient looks great, but I
Well,
always ask the residents, did we stroke the patient?
yeah.
Like a joke, right? But they're not having a deficit.
Did you guys do subgroups? Did you look at motor specific and how the DWI and motor in cortical spinal tract versus other areas? Because a lot of these I imagine were areas that we can't really measure. And even in the Supramax, the reason you can get a safe Supramax is because that part of the brain's not working, right? That's just it. It's already disrupted in some way or compensated for.
Yeah.
But it may be a good project to look specifically
Yeah.
at cortical spinal.
Yeah, no, we did not. I think that's a great idea. You will need a lot of cases. I mean, thank
Yeah.
God I don't recall having any plegic case
Yeah.
out in this cohort. We have a lot of cases where the patients wake up weak and with SMA syndromes, and a lot of patients get worse after surgery. But
Yeah.
for a permanent deficit, yeah, we're just very cautious with those cases. But that's a great idea.
Did you happen to get any feel from the data too, if there were any changes in blood pressure parameters in the postoperative?
No,
looking at perfusion in those patients.
yeah, we did not look at that. That's a great idea.
Yeah,
I
because
think we can look
presumably
at
that data is embedded in all their critical care data
Yeah.
in the postoperative period.
and even within the surgery, right? Were there any episodes of hypotension during the resection? And maybe
Yeah.
that's a very good idea. And that could contribute to worsening deficits or a higher degree or higher volume of the restricted diffusion. That's a great point. And we would have
And then
done
your time frame for the image seemed like it was a window up to about 72 hours, right? In the post-op.
pretty much, you know how it is. Sometimes you finish
Sure.
late, and we don't like to get images at night in general because we've had several cases where the patient is moving and then they give him Ativan and ends up like completely sedated. And then, so if they don't get it right away, they get it the next morning, sometimes within 48 hours. Just that.
Well, I'm just thinking that if you did it right away, you might miss some of that diffusion abnormality early on. If it's a little too early, if it's a venous issue that's late, and vice versa, you might, if you do it late, you might miss some of that early stuff.
Actually,
So there may
maybe good
be,
you just look at all
stratify.
the relationship of the timing of the post-op MRI and
Yeah.
the that's great. I think we could do that.
Yeah, put it
That's-
in bins, put it in less than 24 hours, 24 to 48, and then up to 72, and see if anything comes out from that. But I think there's a lot to be done here that can help us kind of dictate, you know, when we should be mindful of when there's a problem. Because if there was something that we're concerned about, can we actually push a perfusion pressure a little bit more if there was an issue, or could we worry about an improved rheological factor if there's a venous infarct? All things that can help our patients, I think, in the long run.
Yeah.
So, that was fantastic.
So what do you think? What do you think's the answer here, right? Because we can obviously, I see you guys are doing dynamic subcortical stimulation, right? We can map the things that we can map, specifically language and motor really well. And if you got to trust monitoring. If you don't have a deficit at the end of the case, you're probably not going to have a deficit unless that stroke evolves over the next, subsequent 12 hours or so. But what about the things that we can't measure? Things that are a little more, like cognition, like you were saying, or some of the more difficult things. Is the answer going to be in preoperative network imaging, or is it going to be in more complex intra-op mapping? Where do we go to get better at this so we can extend the resection?
I don't think you can, there's more mapping, and yeah, sometimes patients get tired and you just want to get the tumor out. How much can you map? One obviously thing to notice is be cautious at the bottom of the cavity with the use of bipolar. Sometimes I just switch to microbayonets because then I don't have the temptation of using it. Even if you have it in your hand, you press the button. I guess you could use, I don't use the sonoped, but some people do sonoped and then they don't have to. But again, you get bleeding, and you have to cook it. And be cautious about these deficits that you will need to account. It's not just, okay, I found this tract now, but this tract could get devascularized later on as I remove the tumor, and that may lead to a deficit. That may lead to the deficit. And obviously, passage vessels are critical. We do a lot of window approaches where we make 5 to 6 windows and leave veins, leave arteries, but those are typically more at the surface level. I think the deficits that I'm more worried about are the white matter level, that are, that may be more severe.
Definitely. All right, guys. Well, we're right at the 30-minute mark. It's been a great conversation. We appreciate you coming on, as always, and we hope that you'll be back. Thanks everyone for watching at home, and Chris, always a pleasure to see you.
Thank you so much, Chris and Randy. Thank you.
Yes, thank you. We look forward to your next submission to the JNO. Take care.
Yes.
Thank you.